About 3 weeks after surgery, and certainly after 6 weeks, we're going to want to look for and treat any adhesions or deep scarring that might have occurred in the limb as a result of changes and muscle damage that will happen under any compressed zones in the leg, and then also look for any areas where we've had that muscle fiber disruption. So I'll always start at the tourniquet site because I feel that sometimes the tourniquet actually, though it's not on the leg, changes in the muscle have occurred that will almost create an internal congestion. And we want to open that area, improve the blood flow and the lymphatic flow so that swelling, all of the residual swelling, can move out of the leg. And in particular, when you have a patient post-knee arthroscopy or post-total knee replacement, and they come to you with persistent swelling, even up to years later, go look at that tourniquet site. It's highly likely that they have this internal physical tourniquet type effect going on. And if you can work on that and loosen that tissue up, then the swelling has a chance to move out. It's been my clinical experience also that when I work in the area where the tourniquet is, that can actually, for some reason, even help gain some of our last degrees of range of motion. Go figure, but the myofascial system has so much to offer us. So again, I'm going to be doing deeper work. I'm going to take massage cream, and now I'm going to go in deeply. I'm going to watch my patient's face because here I am going deeply. I want to stretch fascia. I want to look for any fibrous bands. I want to look for thickness in the tissue. And sometimes, of course, I know we've got the femoral nerve here, but sometimes you'll feel kind of a bogginess. And that bogginess is congealed, either brawny edema or pitting edema, or even just a change in the subcutaneous tissue. So do long strokes, feel for a change in tissue integrity, and mostly I work transverse to the structure that I'm trying to work on, at least initially. So big long strokes, and then what I will do is systematically go through every muscle because we saw that those, yes, there we go. We saw that those fiber disruptions occur randomly, mostly throughout muscle bellies in the affected limb. So here we find some fibrous changes already just at 3 weeks. It's a little tender for our patient who's trying to keep a smile, but okay, we back off to make it tolerable. And once I find some of these fibrous adhesions, I'm going to start a transverse press and stretch kind of technique, and I'm going to watch the clock. I can get the biggest bang for my buck at about 2 to 3 minutes. So the connective tissue is going to give the most within the first 2 to 3 minutes. That's kind of the hysteresis effect. So I'll do that. And then after 2 to 3 minutes, I'm going to do a longitudinal stroke. Kind of move any swelling or microedema. Remember the pictures I showed you, that microedema between every muscle fiber. Oh, very nice. Okay, good. And then I will go after a different muscle. So here, lateral quad, yes, another spot. Remember, the ischemia reperfusion injury occurs throughout the entire limb. So it's not selective to the muscle. And if you look how far above the knee I actually am, don't just focus your techniques at the local surgical site. Move and check the entire limb. Okay, so let's say I've done that for 3 minutes, then up we go. Good. And I might come now to the medial aspect. Yes. Yes, right there. You can feel a nice fibrous band, a little thickening. Yep. In the medial quadriceps. And again, 2 to 3 minutes. And if you can do this now 3 weeks post-surgery versus 3 months post-surgery, or even 3 years post-surgery, you're going to have such better effects. The connective tissue here is now very, very weak in the first 6 weeks. It begins to strengthen in the second 6 weeks, and of course by a year it's going to be pretty solid, but still responsive, although it will take much longer to work through. So as you can see, I'm going transverse, I'm going longitudinal, and although I'm treating this young man in supine, the next time we see each other, I would put him in side lying and treat both the hamstrings and the region of the IT band as well. So going lower, now, a lot of times we wouldn't even imagine that there's something going on in the calf, but yes, you get a little nod, little smile. So here, lateral gastroc, again, press and stretch, push and move through the fibrous tissue that you feel. 3 minutes, and then move up, longitudinal, and go down. And I know in particular we have something in the perineals, although I worked on that last time, so it's even better. It's better today. Yeah. Good. We'll find some new spots. All right. So that is the press and stretch technique that is going to be very, very effective in working with those muscle fiber tears throughout the limb. And then, of course, you are very aware of how to work in and around the knee to reduce the local swelling there. Okay. Yeah, good. When you're working with swelling around a joint, there are a couple of things to consider. There's going to be superficial swelling that we are going to use light strokes to reduce and move up more towards the heart. But the longer the swelling stays in and around the joint, particularly the concavities around a joint, the greater the tendency for that swelling to thicken. And if there has been surgery done in a joint, we always are going to have that concern of something called arthrofibrosis. So arthrofibrosis is when blood is left behind in the joint, and blood in a joint creates really massive adhesions. So in and around the knee, for instance, everybody is very, very familiar with scar mobilization, and we teach that to our patients. But in and around the knee, I think that we can do a little bit deeper work. This is 3 weeks post-surgery, so I'm able to get in, and I like to imagine the swelling in this case to be similar to pushing Jell-O out of a sponge. I want you to remember the pictures of the swelling between pretty much every cell, and while I'm avoiding the incision sites, I'm definitely just going to be doing a very local, pretty firm pressure to move this swelling as best as I can through and out the joint. And don't forget, in the knee area, there's a posterior recess as well. In the popliteal fossa, we can really get some thickened swelling in that area as well. So I go in with 2 hands, I lift up, I know where the tibial nerve is, I know where the perineal nerve is, and I'm going to be a little bit more dramatic with my pressure in this area. Yep. And I will always finish deep work, whether it's my press and stretch technique or my local technique to rid the patellar recesses of swelling. I will always finish with long strokes up the leg. Now, if you want to improve flexion, I highly recommend working the knee as best as we can. We're going to bend as far as we can possibly go with comfort. Right about here. We're going to support it. But here, if you look, you can see a lot of tension in the rectus femoris. And as the knee ages, they see that the rectus femoris tends to get fibrotic. And what that's going to do is it's going to make it even harder for the patella to move distally during knee flexion. So we're going to do a press and stretch of the rectus femoris, and at the same time, we're going to do an inferior glide of the patella. And the beautiful thing about this technique is it's now multidimensional. It's now three-dimensional. So we're press and stretching. We're working out dysfunction in the rectus femoris. We're pulling the patella inferiorly. And my little fingers in the suprapatellar recess are helping to break down any adhesions in that area. You okay? Good. And by doing this technique, we can actually beautifully gain more range of motion without really having to do an angular push on the knee. So just by those few little minutes that I just did, we're going to see if we can get any further in the bend. Yeah, a little bit right there. So we're going to get a little bit more here. Good. And again, try to get the soft tissue to release rather than cranking on the knee. Okay. And sometimes, you tell me how it feels, a little under the patella. So you're
lateral side.
On the lateral side. So here and lateral. So that's another fun thing to do with your patients, is every time you gain new range, ask the person where they feel it. They will always feel it somewhere new. And work through that. Again, you can feel the fibrous bands. You okay? Again, working, I'm avoiding an incision here, but I'm working through a tight fibrous band. Okay, let's say we do it 2 or 3 minutes. How's it feeling? Still feeling it? A little bit better? Okay, good. Then let's bend more. Good. And where do you feel it now? This time on the medial side. So what we're going to do, we are not going to angularly push this knee if we don't have to, and we're not going to do a translation on an ACL and meniscus repair. So what we have is we have the soft tissue. And what studies have shown is that in the first 2 weeks of immobilization, it is only the soft tissue that tightens. So if we can gain most of our range within the first 2 to 3 weeks of immobilization, then we have the greatest chance of getting where we want to go simply by press and stretching through tight myofascial structures. Okay, and it goes on like that as you're working with your patient.